Hi, everyone. We'll get started for today's rounds. We have today Dr. Frances Leung. She's a community rheumatologist practicing in Toronto with a satellite practice in Sault Ste. Marie. She is affiliated with Sunnybrook and is on the Faculty of Medicine at the University of Toronto. She graduated from medicine at the University of Alberta in Edmonton at the age of 23, and then she came to Toronto for her postgraduate training. She obtained her fellowship in rheumatology in 1981 and in internal medicine in 82. She has her master's in epidemiology and biostatistics from McMaster University, and she has a special interest in fibromyalgia and, sorry, I'm going to mutilate this, psoriatic arthritis, the former being a rather neglected but common chronic medical condition. She was a member of the expert consensus panel for fibromyalgia, sponsored by the National ME/FM network, and she is interested in managing healthcare and was a finalist in the Lieutenant Governor's Visionaries Prize in 2017. And last year, she was the lead assessor for rheumatology for the College of Physicians and Surgeons of Ontario. Welcome.
Thank you very much. I'm quite honored to be asked to give a talk. I am very interested in psoriatic arthritis, and I think that you might get me talking too much, so you have to shut me up. And anyway, so just so, because I think I've got a lot to say, and now not everything is in the book. So this is based on many years of observing patients, and I guess I do follow my patients fairly frequent and long, and so that it sort of give me an extra advantage. So firstly is that I have nothing to disclose. And so today I want to learn how to identify patients with psoriatic arthritis and know what other things that come up with it, and some update on the treatment available. The thing about psoriatic arthritis is not really all that well known among the community. And I find that there is often missed because we don't either find the associated rash with it, or we appreciate it. And what got me kind of interested in this is that some years ago, and I was at the ONA, now the Holland Center, I used to get called in to see patients for their before they get their knee surgery. And so they were diagnosed with osteoarthritis. And so I asked them and said, when was the last time you can sit on your heel? And most of them said, no, I haven't been able to do that since I was a teen. And so through the history very often and the physical examination, they often show signs of rashes. And so I think that this is probably one of the most underdiagnosed condition. But the importance of diagnosing this is, especially in the setting of what we call osteoarthritis, is that it is amenable to treatment. It's amenable to control if you get started on the right medications, whereas diagnosis of osteoarthritis often lead to a therapeutic nihilism. So, yeah, it's just old age. Wait until you got it bad enough to get a new knee, for example. And that's kind of unfortunate. So the psoriatic arthritis is among the class of arthritis that we call seronegative. But this is probably not quite entirely correct, in the sense that the psoriatic arthritis also overlap a lot with rheumatoid arthritis. And in fact, in my experience, perhaps even with lupus and scleroderma, although to a lesser degree. So I don't think that we should look at each one of this as an individual separate condition. So just to get over the dry stuff, is that, you know, the incidence varies, but usually it's about in patients with psoriasis, about 3 per 100 per person year, 100 person year, and about 30% of patients with psoriasis would develop a psoriatic arthritis. According to the Casper criteria, go over that, the prevalence is about almost a quarter of that. These most commonly is between the age of 20 to 40 years of age, and it affects both male and female equally. Now, it says it's mostly in white people, but I think this is probably because most of the research has been sort of Eurocentric or in North America, but certainly we see them in other I lost my mouse and other kind of ethnic group. Okay, so this is a CASPAR criteria for psoriatic arthritis. So basically is that this is anybody that presents with inflammatory arthritis involving the joint, the spine, or entheses, and you count the score. And so if you have at least 3 points, then it's suggestive that you will have psoriatic arthritis. So obviously, you have to have evidence for psoriasis. And so either current or past personal history or family history would count as 1 point. Now, if you actually see it, then it's a 2 point. So nail dystrophy is counted. So it's supposed to be negative for rheumatoid factor, although occasionally it could be positive. But the presence of dactylitis is very telling, and we'll go over that later on. And so, of course, if you have radiographic changes, then that will make it much easier. So now, psoriatic arthritis is associated with a number of things, and most commonly is that there's obesity and cardiovascular risk factors. And we should always look for presence of uveitis and inflammatory bowel disease. However, probably not as appreciated is the presence of reflux, Raynaud's phenomenon, and certain types of alopecia. Now, going back to the CASPAR thing, I think one of the reasons why psoriatic arthritis is not as recognized or misdiagnosed as other things is the fact that we may not actually identify the psoriasis. Firstly, is that if we ask the patient, do you have psoriasis or family history of psoriasis? A lot of people really don't know what psoriasis is. And so if that's the way you pose the question, you might not get the right answer. So usually I would ask them and say, do you have any problem with itchy skin, dry skin, fissuring of their fingers and heels, that sort of thing, or even itchy ears? Because a lot of times, they would not think of dandruff as a symptom of psoriasis. So you have to really give them the symptoms rather than the diagnosis. Otherwise, you might miss the opportunity to ID that. So genetics, it seems to be there's a good amount of genetic risk factors. So among the first degree relatives, you have 30 to 45% risk of having psoriasis and at least 15% risk of developing arthritis. Now, there are a number of HLA genes or loci that are associated with this, but maybe I won't go through that too, because I don't think it's clinically relevant. Yes, they are associated with increased risk of synovial and cutaneous disease and entheses as well. So what would make a person with psoriasis develop this? So number one, of course, is genetic susceptibilities. And the person who has obesity, hyperlipidemia might be more likely to. And sometimes is there certain areas of psoriasis involvement. For example, in the DIP joints, you're more likely to develop arthritis in that area. So what triggers this? Very commonly, injury. In fact, sometimes infection. I'm not sure obesity necessarily, but about 70% of the patients, actually the skin changes can precede the arthritis. However, that means 30% of them may come with or after. So in essence, sometimes is that you may have to diagnose psoriatic arthritis in the absence of psoriasis. And some doctors may not be quite prepared to do that. Now I do, and I call them psoriasiform. Anyways, so there are some genetic things that would suggest that if you carry the B27, you may have a shorter latency. But again, that doesn't really matter. So one of the phenomena that is sort of central to psoriatic arthritis is the Kerpner phenomenon. Okay, this was described last 2 centuries ago, where the patients with psoriasis very often develop psoriasis at the site of trauma. And this happens in a substantial number of patients. And so we think that why some of these patients develop arthritis post-traumatically is that there is a deep Kerpner phenomenon occurring there. Sometimes, or there has been some discussion about, having gutty psoriasis in children after streptococcal infection. And in fact, there's laboratory testing or experiments where they apply certain microbial things to the patients. That seems to increase the activities. And so there we find the streptococcal and staphylococcal antigens in patients that could sort of stimulate the involvement of the skin, and people with HIV has been found to have that as well. Now, I guess the psoriatic arthritis has become to its own as a result of a seminal paper by Moll and Wright, and they have collected a cohort of patients with arthritis and psoriasis. And so they have sort of sorted them out into different patterns. And so most commonly is the asymmetrical oligoarthritis. Usually what we mean is less than 5 joints. There's a 15% with symmetrical polyarthritis that are called rheumatoid-like. And then 5% are only the DIPs. 5% have what we call the arthritis mutilans, and it's a really devastating disease. And 5% is spondyloarthritis. Now, over time, things may have changed. And so, we see that you can break it down into a little bit more finely, but it doesn't really matter. I guess the main thing is that is still majority of the conditions is still holds. So what are the hallmarks of psoriasis? In fact, when you see this, it's psoriasis, psoriatic arthritis. I mean, I get to the point where if I see certain things, I just say, this is it. I don't care what else comes. So firstly is enthesitis. Okay. In fact, I even move to change the term of psoriatic arthritis to enthesopathic arthritis, because there are a number of other skin conditions that might give you the same kind of things, such as eczema. I see that a lot, particularly in the Orientals. And so they have exactly the same thing as psoriatic arthritis, but so it's just that, they don't have psoriasis. The other thing that's a hallmark is dactylitis. I don't think there's anything else that would cause this kind of phenomenon. And lastly, although quite rarely, is that you might see edema, usually of the hands or feet in the same part where active arthritis is present. And usually those edema do not respond to usual diuretics. They only respond to a successful treatment of the underlying arthritis. So it's just a few examples of it. I'm sure you're all familiar with this. I lost my mouse. I'm not quite sure. Oops, not quite sure where it went to. Oops, I can't. I went to the wrong. Sorry, I need some technical support. Sorry, I lost my mouse. Thank you.
You're welcome. You just went to the
I went back.
screen.
Yeah. Oh, I'm sorry. Okay,
That's
but I
okay.
want to go back to the previous slide.
Okay, hang on. Let's do this.
Sorry, I'm not very okay. So I have my okay. So basically, is that you can see that there's DIP involvements in here, but it's asymmetrical, unlike in rheumatoid arthritis. There's MCP and PIP involvements, and this finger looks almost dactylitic, and so is this thumb. And here is a typical finding of dactylitic toe. We call them sausage digits. Now, so there's some enthesitis in here, although this may not be the best example, but it also concomitant with a bursitis and the ankle arthritis in here. And this is actually more of enthesitis in here. Now, the other thing about it too is that tarsitis, which is the involvement of the mid-tarsal joint, is also fairly typical in psoriatic arthritis. Here is a case of arthritis mutilans. So fortunately, we don't see that very often, and I would hope that with our current availability of effective medications, we won't see this. But this is where the digits just sort of, the joints just totally get chewed up, and the fingers are quite flail. So the other thing is the spondylitis. Again, we usually talk about spondylitis as sort of a variation of the ankylosing spondylitis, but basically is that there are some differences between the routine ankylosing spondylitis and the psoriatic ankylosing spondylitis, in the sense that the syndesmophytes tend to be a little bit more exuberant in the psoriatics than the straight angspons, and they have more women in the psoriatic type. And so the thing is that sometimes they come up pretty well similar, but there are variations of spinal involvements that is probably not actually included in the routine talk about the psoriatic spondylitis. But here's a what we call PASQ, which is a psoriatic epidemiology screening tool. It's a questionnaire that you might use in the office. It's just 5 questions in here. So, have you ever had a joint problem, and did your doctor ever tell you about the psoriasis? Although, like I said, I would rather you ask them specifically about symptoms of psoriasis. And did your fingernails ever have pits? What I usually ask is that, did your doctor ever tell you you got fungus nail? Okay, because fungal nails and psoriatic nails are very difficult to differentiate. Just clinically, they look quite like each other. And have you had any pain in your heels? Again, is the most common place of enthesitis. Okay, and did you ever had a completely swollen finger? Again, with the dactylitis. So if you have more than 3 points, you're likely to have psoriatic arthritis. So now, because the diagnosis of psoriatic arthritis is so sort of predicated on the finding of psoriasis, I think that we need to know what is psoriasis and how do you pick them up. As you say, there are many different types of psoriasis. I mean, obviously, if you see a good patch of it, that's easy, but there are lots of people who have early signs of it, and unless you are familiar with this, you may not actually see them. In my examination of patients, anybody who comes in for arthritis, the first thing I do actually is I feel up their elbow, the elbow. It's amazing how much information you can get just by rubbing their elbow. So the thing is that, typically is that you get plaque psoriasis. The majority of the patients have that, and then a good number have scalp psoriasis, and I usually run my hand through the hair. And then there are nail psoriasis, so you always have to look at the nails. I mean, that's one reason why I like rheumatology, because a lot of times is that the clue is really, really tiny, and you feel a little bit smarter. Anyways, now don't forget about the toenails. I don't know, a lot of, even among my colleagues, don't look at the toes because it's too much trouble to take the shoes off and the socks off. But it is very important to look at the toenails. So the gouty psoriasis can be very, very small, and some people may not appreciate that as psoriasis. Now, one tricky one is the inverse psoriasis. So whereas psoriasis tends to be on the external surface of a joint, like the elbows on the outside and the knees, but these ones are on the inside. So it's on the folds rather than on the external side. So sometimes we may not look in there too well. Now, very rarely are people with erythrodermic psoriasis. Although most of the time, if they're really erythrodermic, they're quite sick, and I'll show pictures of that. But there are very commonly, people don't actually have the erythema, but they're just shedding all over. They're just dry all over. They walk into your office and they leave a trail of snow behind. So those people are likely to be psoriasis. So when you take the shoes or the socks off, okay, and you see all kinds of white flecks inside the socks, think of it. And then there's a rare pustular psoriasis. Sometimes it's palmoplantar. And so that is important. It's quite dramatic when you see it. So this is typical usually at the nape of the neck. And they may not be symptomatic. And so for women, you really have to sort of lift up the hair to check that. And the other part is also behind the ear and in the ear. Sometimes it's in the genitalia, and very commonly is in the gluteal cleft. Again, that's not an area that we often look into, and patients are often too embarrassed to tell you. And so usually when I check the back, I usually look at the back and I just quickly pull off the pants and look inside there. And that way, you might be able to pick up some of the hidden areas. So the nails are very easy to find out if they're like this. So you can see that there's onycholysis, that the nail plate is lifted. It's like in here, so the red part digs into the nail plate, and you can see it's irregular. You can see the pits in here. And so if you look at it on the profile, very often there's junk underneath it, and it looks like it's they're dirty, but they're not. And often they're ridged, okay? But often it's not as obvious as that. You might only have a few pits in a nail, and that's it. Technically, if you count more than 10 pits in a nail, that's a psoriatic nail. But sometimes you can have 1 pit, 2 pits. So the thing is that you just have to keep an eye out for that. So this is a typical psoriatic plaque. It's generally well defined, and there's scales. Now, as I said, don't dismiss the people with eczema, because very often they can have similar type of arthritis, and very often there are overlapping eczema and psoriasis in the same patient. And so the difference is that eczema tends to be a little vague in terms of where it is. So it's not well defined, and it's generally tend to be on the flexural side, and they tend to be much itchier. So here's another nail pitting. So sometimes you have to look at them in the light. You have to sort of roll them around a bit in order to appreciate the pits. So the elbows, as I say, if you rub their elbows, very often, you might actually catch a plaque, but subtly, sometimes it's just rough, and it takes some time before the plaque actually forms. So if they have very rough elbows, especially more on one side and not on the other, chances are you're probably looking at an early psoriatic. And so this is a guttate. You can see that they're very, very small. So sometimes it's that if they aren't large enough to see the scale, you might miss it. So if you see somebody just sort of like peppered with it on the trunk, think of it. And again, in the ear. So that's why I always ask them, did you ever have itchy ear? Sometimes it's really deep in and patients don't know. And it's funny when I ask that question, it says, well, geez, I never thought of that. I've never asked, kind of thing, but I've been troubled by it. And the belly button is a typical area as well. So have a quick peek sometimes. Now, this is an erythrodermic person, and it's quite severe. So you can see it's quite red, but you can see it's really, really, really scaly all over the place. This is a palmoplantar. They're pustular. And so it's very, very difficult for the patients, especially if it affects the feet. They find difficulty walking about. All right. So the other thing is that, they often have this sort of thickening in the heels. So sometimes it's not that obvious. They just think, oh, it's a callus or something. But interestingly is that sometimes it's that they split. They have deep fissures, and this is commonly in the fingers and the toes and the heels, and it's worse in the wintertime. I've had one patient who was so deeply fissured that he actually bled down. And so the reason why they fissure is just that in psoriasis, the pathophysiology said that there's a massive increase in the keratinocyte growth. And so just think of it, if it's like a souffle, if it gets too thick, it will split in the top type of thing. And so I was just telling Kathy about this, is that, you know, in the old days when the patients had a post-traumatic car accident, for example, and they were incapacitated and they were sent to see an independent medical examiner, and they said, well, it's been bedbound for the last year, and he says, well, how could you be bedbound? Look at your feet, you know, it's so thick, you have calluses in there, so there's no way you could have been bedbound. And so it's in fact probably the patient's psoriatic arthritis. But anyways, so this is how it could be just thick. Okay. So the other things about it is that there is also oral psoriasis that we probably never heard of. So sometimes, and often we would dismiss it, it's no big deal, you know, like tongue fissures, geographic tongue is very common. And then, you know, so sometimes it may be just red patches. So we rarely ever do that. Now, interestingly is that mucosal ulcerations, which often is quoted in lupus, but I think that the mucosal ulcerations is also quite common in psoriatic arthritis. Occasionally, they can get desquamated gingivitis, but unless you're a dentist, you're probably never going to see it. But ulcers, do think of that. So there's a geographic tongue, and that's the thing in the mouth. Okay, so the other thing is that, you know, they very commonly, well, not very commonly, but they're very common, what we call common is in terms of extra-articular manifestations, is that we need to look for is inflammatory eye disease, so acute anterior uveitis. And actually, maybe more commonly than what is quoted here on the slide is an inflammatory bowel disease, Crohn's disease, and ulcerative colitis. So, you know, as part of the sort of functional inquiry, we usually ask them about their bowel habits. Okay, always look out for back problem. And these ones are not all that commonly quoted, but reflux is very common in psoriatic arthritis. And I suspect that there might be overlap with the scleroderma type of things. Because very often they have like free reflux. Now, alopecia, there's different types of alopecia. It's usually alopecia areata. But interesting thing is that very often in women is that they have this high forehead. And sort of like, I think the Queen Elizabeth I type of thing. And in men, very often their calf hairs drop off. So we usually tell them, I was taught to tell them that is, you know, you have a bald calf because of your socks, but it has nothing to do with socks, because very often it's on the outer side of the calf, not the inner side of the calf as much. Psychiatric disorders. So there is an increased frequency of depression, and there's been some quotes about the bipolar disorder as well. So this is an example of anterior uveitis. So it's painful, red, blurry, and so they need urgent medical care. So Crohn's disease and ulcerative colitis, so I'm sure you're all familiar with that. So this is another thing that is not often quoted, and I see this an awful lot. This is MGUS, and this is monoclonal gammopathy of unknown significance. And so it's not that common in the general population, but I see it so often among my psoriatic arthritis. I'm almost getting to the point is if I'm not sure, but they got an MGUS, you know, I'm almost sure that they're going to be. Now, most of the time it's fairly benign. It's very rarely would progress to multiple myeloma. So the thing is that 9% of the MGUS people have rheumatic diseases, and rheumatic diseases certainly increase their risk a bit. And it tends to be the sort of what they call non-antibody rheumatic disease. So these seronegatives actually may have a slightly higher risk of progression than the routine ones. Now, so the types of clinical findings is that, you know, this is typical of a psoriatic arthritis being oligoarthritis, and the knee is very commonly involved. And you can see both knees are involved in here. There's an obvious gross effusion. This one is not as swollen, but you can see that here underneath in this one is almost like a little thyroid sitting here. That's actually infrapatellar effusion. So very often, I mean, I think some people might even inject it from here or approach it from here. But sometimes it's that people may not appreciate they have arthritis because unless the effusion rises above to the level of the tibia, you can still bend it pretty well. So this is a DIP. You can see that usually is where the nails are involved. Usually is the DIP is very often is involved. You see, this is a good nail, and this DIP joint is not bad. So it's got a big finger there. So this is sort of another typical findings of it in here, the DIP. Actually, I want to show you myself. I diagnosed myself as psoriatic arthritis, even though I don't really have psoriasis, but I do have a couple of patches of eczema, and I have a rheumatologist. Okay, I'm not looking after myself, but I'll show you something later on. But so the thing is that very often you get really big knuckles. I don't know if you can see that. So on the side it comes up, and you can see here is that my finger has a big bump on it. Now, most of the time people say, well, that is Heberden's. It's not. Anyways, so sometimes it's that, especially in patients with polyarthritis, may think, oh, it's just rheumatoid arthritis. So sometimes there are certain things that might want to differentiate it between the two of them. So usually psoriatic tends to be asymmetrical in oligoarthritis, whereas rheumatoid arthritis is symmetrical, and usually is seronegative, and the anti-CCP is negative. However, I have had patients who had a positive anti-CCP and a low titer rheumatoid factor. Nodules are generally absent, but this is definitely psoriatic, and the DIP involvements, okay? And so on the x-rays, there are some different changes. So these usually the rheumatoid is more marginal. And the one thing about psoriatic arthritis is that they tend to make a lot of bone. And in fact, patients with psoriatic arthritis, if they ever go for joint replacements, they have a much higher chance of developing heterotopic ossification in there around the joint replacement area. Maybe, so I think we probably are just repeating ourselves in here. So in terms of diagnosis, so diagnosis is clinical. Because usually the blood tests don't tell you very much. It's seronegative, and very often the inflammatory markers are very bland. And in fact, that is one of the reasons why a lot of doctors might not diagnose it, because, or tell them, oh, there's nothing wrong on your blood test, kind of thing. Now, like I say, the serology is generally negative. If they have a rheumatoid factor, it's very low titers, just borderline. And if they have ANA, interestingly, is that very often, in fact, almost 99% of the time is speckled and homogeneous. Okay, it's not just one or the other, but often the two. So I think that also might have a role here. Just again, is as a tip as to what you're looking at. So imaging technique. Well, I say, if you see somebody with a virgin arthritis, if there's the first attack, X-ray is useless. Don't even bother, because it's normal. X-ray only tells you what damage, what changes there are. And so, if you want to know, especially if this is the first attack, you need to know, is it inflammation? Okay, because inflammation requires treatment as soon as possible. So very often in the first time is I'd rather you do an ultrasound, because if you demonstrate any sort of synovitis, tenosynovitis, that is very helpful, okay? And so the plain radiograph primarily just sort of looking for enthesitis or deformities or damage and that sort of thing. But usually there's already something happen, and it wouldn't happen overnight, so it will take some time. And so if you want to, I suppose you can get an MRI. It certainly is a much superior imaging technique, particularly when it comes to the spine. I would never do a CAT scan of the spine, actually, if you are concerned about anything. It's just to give you much more information that the CAT scan won't tell you. Okay, so this is me. Okay, my rheumatologist, they gave me a requisition for x-rays, and I've been sitting on it for a long time, never had time to go. So one day we had a giant snowstorm and everybody canceled. So I went downstairs and had my x-ray done. So there it is. So here is the heel spur. Okay, so you can see that this is enthesitis. It's a phenomenon where the bone grows into the tendon, and this is when it because of inflammation. Now, the spur is there after the inflammation. It's not before the inflammation or with the inflammation. So you can have pain and no spur, or you can have spur and no pain. Okay, all it means is that sometime in the past that person has had enthesitis. Okay, so it doesn't diagnose, with the active disease, but if you see that, especially in this case where it's quite prolific, this is likely a psoriatic type or seronegative arthritis, and psoriatic arthritis is good. So this is my finger. So I've always wondering, I got really big knuckles, and you can see how it just bumps right up. And so the reason for it is that, the joint is still good, but look at this part here. So this is the enthesitis or enthesopathy. So this is enthesophyte. So it sticks right up in the extra bone. And this is my pelvis. So you can see, I mean, I got pretty good sacroiliac joints, and I think my hip is not bad. But look at this. Okay, so the iliolumbar ligament is ossified. I've had inflammatory back pain for quite a while. So anyway, so I said, oh, that's interesting. I don't see that very often. And here's my DIP joint. Again, you can see this giant enthesophyte coming up. So this is why I have a bump, and this is not Heberden's nodes. And now this is not me. This is some poor bugger with mutilans. So you can see that this is tough. This is osteolysis. So actually the inflammation just caused it to just wear down the whole bone. So that's why this one is getting flail in here. This is psoriatic spondylitis. Okay, so you can see, I mean, people who are familiar with ankylosing spondylitis is that, the syndesmophytes tend to be very elegant, very delicate, but in psoriatics, they tend to be like huge chunks of bone that comes up. Okay, and interestingly, like the disc have gone down a bit. Yeah, darn, I forgot to put the MRI down. Okay, so here's a condition called DISH. We in rheumatology tends to treat it as if it's a separate issue, but I honestly think this is a variation of a psoriatic spondylitis. It's basically is that there is apposition of bone, and this is typical enthesopathy, and so the anterior longitudinal ligaments get ossified, and so if you have ossification of more than 4 segments, it's called DISH, and usually it's that the sacroiliac joints are clear. So it's not spondylitis in the classic sense, because usually spondylitis means that your sacroiliac joints are involved. And unfortunately, with our current treatment, for example, the biologics are only available for people who have sacroiliac joint involvement and not otherwise. It might change over time, but again, so they have very exuberant bone depositions. In fact, sometimes is that it can get so big that it causes some dysphagia as well. And I don't know, maybe I wasn't listening when I was being taught, is that we were taught that DISH doesn't really hurt, but it can hurt. And so a lot of times patients have pain that comes around the trunk, and so they feel like they're wrapped in here and they're really uncomfortable, and women don't want to wear bras. But anyway, so think of that. So this is an MRI. of the back. And so what I want to show is that, I'm sorry, I guess I can't really blow it up, but you can see that in the peridiscal area, there is bone edema. Okay, so this is typically in the anterior corner of it. So this is called a Romanus lesion, like this in here. So this is typical of the actual spondylitis. However, in here, this is coming back over the disc itself. And so this is the Anderson lesion. And so there's a little bit of difference in that. So in here is a case where you can see here on the T1, this is dark in this corner. On the T2 is a little bit light. And the stir sequence is the one that picks up bone edema. And so you can see that this is quite bright in here. So this is an area of bone edema, it's an area of bone inflammation. So I'll just word to the wise, if you have somebody with a back problem that you wonder if it's inflammatory, ask the radiologist to throw in a stir sequence, okay, that is short tau inversion recovery, so STIR, because the stir sequence will bring up anything that has high water content. So for example, in here, you've got the spinal canal, so it's full of fluid, so you can actually see those little tiny roots coming out, but it will pick up bone edema, which is sign for inflammation. Okay, now as an aside, very often the radiologists do not report on the facet joints. I always put in there, please comment if there's fluid signal in the facet joints. This is a very neglected area of back management, so the thing is that if there is a fusion in the facet, there is inflammation, although they don't usually care about it. So management, I think we'll just quickly talk over. I mean, there's nothing that you don't already know. So basically, is that with any arthritis, doesn't matter, psoriasis, rheumatoid, any kind of things, I always tell my patients this: arthritis is like cooking chicken. Okay, so in a normal raw chicken, the cartilage is quite firm, very smooth, very, you cannot deform it, and you can take a lot of pressure. But if you have arthritis, it's like throwing it in a pot. It could be simmering, or it could be a hard boil. Okay, but regardless, it's just that if you expose that cartilage to inflammation or heat long enough, hard enough, it'll cross that sort of line, and then the cartilage will change. Once the cartilage denatures, then it is subject to mechanical pressure and deformities. And so once it's softened, it'll squish down, it might smush off. Okay, that's why you have meniscal tears, and that everybody's going to get meniscal tears, I suppose. But so once it's down, the bone is no longer cushioned, and so the heart bone is going to take pressure. So it's like if you hit a nail on the head long enough, the head of the nail comes out, it splays out, so the surface is bigger. So that's why you have the osteophytes. Okay, it's not traction. So if your bone deforms, then that extra bone is there where it shouldn't be. So if you bend it, it's going to jam. Okay, so it will affect the function, even if the inflammation is gone. So I usually tell the patient, we need to turn off the stove. Now, if you don't want to turn off the stove because you're afraid of your medicine, at least try to turn it off every once in a while. It's still better than nothing. Okay, if you can turn it off every once in a while, then you delay the cooking. So conventionally, we're kind of scared, and so we use NSAIDs. NSAIDs, they're okay, they're better than nothing, but they're usually only about 60% effective. So if you have a mild disease, 60% might be sufficient for your thing. But if it's a major disease, 60% is not enough. And as in rheumatoid arthritis, we only have 6 months window to get that under control. If you don't control it within 6 months, they're going to go on to deformities and damage. So although psoriatic is not as violent as that, but it can be sometimes. It can have a really massive attack in a joint. So sometimes it's that you don't really have a lot of time. So I usually tell patients is that, the anti-inflammatory is like throwing buckets of water on the fire. It's okay, if it's small fire, but if it's a big fire, you need to call the fire truck. Okay, so I use steroids. Now it depends if it is just 1 or 2 joints, the local injection would suffice. But if it's like multiple joints, I wouldn't mind using steroids. But the problem about using steroids is that in the old days, we used to do little bits and then keep them on it. That's where the problem comes. As you know, people with asthma, they go to emergency and they get whacked with steroids, maybe once or twice a year sometimes. And in fact, there's been studies that shows that, if you use that type of steroids in that way, the bone density doesn't really change that much. So again, with prednisone, for example, is that, it usually kicks in about 4 hours. And if you don't take another dose, it lasts for about 18. And so the thing is that it is important to hit and run, don't stay. Just like, you don't want to park the fire truck in front of your house, right? If you do, you have no fire, but you can get water damage. But if you have a fire, you better call the fire truck, but they usually do the job and get out. And so the temporary, and you may say, well, what good is that if you're going to come back? Well, the thing is that, at least if you can temporarily shut it down, it still gives you that little bit heads up. But usually is that if it comes back again, then you have to do something else. So, call it the fire truck once, it was an accident, and call them up twice, you got an arsonist, you better get the police out. So this is where we come with the DMARDs, okay? So it's disease remittive agents. So the classic ones, the methotrexate, sulfasalazine, leflunomide, and cyclosporin. We used to use antimalarials as well, but however, with the introduction of the biologics, because there are certain criteria that you have to fulfill in order to qualify the patient for the biologics. So our practice is pretty well influenced by that. So for example, if we put a person on cyclosporin, that doesn't qualify them for the biologic. So usually what we do is that, we start them on methotrexate and then add sulfasalazine or leflunomide. So it's because the criteria requires 3 months of methotrexate, 3 months of methotrexate with sulfasalazine, and 3 months of methotrexate with leflunomide. And if they don't respond to that trouble, then they qualify for the biologic. So I just do that. So at the end of that time, if the patient says, I don't want biologic or whatever, then we'll go back and use the other stuff. Okay, just so that you don't waste a lot of time. Okay. And so, we got 1 million biologics. Every year there's biologics. So maybe I won't go through all that in there. So we have the classic ones, so the original ones is TNF inhibitors. And then we have the IL-12/23 inhibitors, the IL-17 inhibitors, our IL-23. So they have separate ones, and T-cell modulators. And more recently is that we also have the targeted, the JAK2 inhibitors and the PDE4 inhibitors. Okay, so I just want to put down in here is that, some of these are covered only for psoriasis and not for psoriatic arthritis. Some are not covered at all. And some, like down in here, these are covered for rheumatoid arthritis, even though there's excellent evidence that they help with psoriatic arthritis. Okay. So what makes a poor prognosis? Well, usually if it's polyarthritis and if they have dactylitis, and certainly if they have high levels of inflammatory markers, they probably don't do very well. So there are some a subset of patients where they really have massive inflammation in a joint. I've had to, when I aspirate, I would take like almost 100 cc's, all of them. So the comorbidities are very often is that, they might be a little bit overweight, they have increased risk for diabetes, heart disease, depression, anxiety. The mortality rate is no different from the general population, and it's quoted that is 30% of the patients have fibromyalgia. Now that, if you don't mind me, I just want to go through. I swear fibromyalgia is symptomatic of spinal arthritis or injury. And when I did a retrospective review of my patients, and I presented it as a poster a few years ago, So when I looked at back at the cohort of my patients from 1993, and now some of them I followed for 20 years. So not all of them. And so in that, 80% of them have developed some form of arthritis, and 80% of them have psoriatic arthritis. There's a few cases of eczema, and 3 have both of them. And interestingly, 63% of them have spinal stenosis. Okay, and these include fairly young people. We're talking about like in the late 40s. So they would have had started their problem long before that. So I do seriously believe that our current approach to fibromyalgia as a central thing is probably wrong. And I think that they might have had psoriatic arthritis. And in fact, this idea that they have irritable bowel syndromes, many of them turn out to have inflammatory bowel disease. It's just that in the old days, if you scope them this way, and there's nothing to see, there's nothing wrong with you. Well, there's 20 feet of gut in between that we don't see. So we can't say that there's nothing wrong with them. And also now we know that there is microscopic colitis. And so, they could have had the whole problem and not be diagnosed. And so, some of them have Raynaud's phenomenon, and that sort of thing. And so a lot of these symptoms that we see in fibromyalgia probably is maybe a bit of psoriatic arthritis. It's just we never pay any attention to. Anyways, so I guess that's it. All right. So I think I'll try to end the slideshow if I could find the thing. Okay, here we go. Okay, any questions? Am I okay? Did I do something?
No, you did everything fine. If anyone has any questions, just go ahead and unmute. Nobody wanted to challenge me because most of the things. Oh, sorry.
I was going to say thank you very much. Oh, sorry. Go ahead.
I have a question. It's Connie Foster. I'm a nurse practitioner, but I also cover for the Rapid Addiction Medicine Clinic, and we see a lot of concurrent disorder, but also bridging that primary care piece. And just if you could elaborate more on the mental health connection with psoriatic arthritis, that would be great. Thank you.
Oh, well, I'm not a psychiatrist, although a lot of the times I end up doing psychiatry in my practice. Right. Yeah, there's certainly a higher incidence of depression. Now, why are they depressed? I mean, it's probably not nice to have psoriasis if you're kind of, people will likely bully you, especially if you start young, and you're sore, so your disease burden is quite high. And so I wouldn't be surprised. I mean, there has been some quotes about, higher incidence of bipolar disorder as well in this group of patients as well. So there is some suggestions, that there might be some, genetics, and I'm not very good at the medical science part of it, but there has been some suggestions that some of these cytokines or whatever might have some influence on it. But certainly I do see a lot of it.
Okay,
sorry, I couldn't be smarter.
No, I think there is that cytokine pathway to look at as well that I've been investigating in my research too. Thank you.
Thank you. Any other questions? Surely somebody should need to challenge me because a lot of things I say are not necessarily in the books. Dr. Pritchard, you had something?
No, I was just thanking you for your thorough presentation. I really enjoyed it.
Oh, thank you. All right. Yeah, so I thought at least about fibromyalgia, everybody would be asking about that, but please don't send any patients to me. Anyways, all right. So,
seen anyone else pop up?
No, okay. Well, anyways, if you ever, for the people who admits that if you have any questions, I guess Kathy can share with you my email. So if you have any questions, let me know. I'd be happy to reply. Okay. All right.
Thank you so much for presenting today. That was very well done.
Thank you.
I certainly learned a lot, and I'm sure everyone else did.
All right. Well, I'm enjoying Perry Sound. Thank you very much. So I'll go and see my patients to my house calls. See you guys.
Thank you.